Hello dear viewers, in this video I am going to discuss how we should approach distress and agitation in ICU. This is part 1 where I will discuss general aspects including non-pharmacological management and how to identify and monitor such patients. I am Dr. Sunil Garg from Essentials of Acute Care. Distress is common among critically ill patients and it generally presents as agitation, especially those who are intubated. It needs to be treated for patient comfort and to decrease sympathetic tone, which may have untoward physiological effects. The cornerstone of treating agitation involves treating the underlying critical illness and the reason for distress, like the presence of anxiety, pain, or delirium, and use of non-pharmacological interventions. Several conditions and their associated symptoms can lead to distress, like drug withdrawal, infection, dyspnea, hypoxemia, and shock. Strategies to alleviate distress due to underlying illness include simple maneuvers such as adjusting ventilator settings for dyssynchrony and/or derangement in gas exchange, antipyretics for high fever, hemodynamic support with fluid and vasopressor for shock, antimicrobials for suspected infection, and/or heart rate control for arrhythmias. Identify the etiology of distress. Not uncommonly, there may be more than one reason for distress, necessitating combination therapy. The primary cause of distress in critically ill patient include anxiety or fear, pain, dyspnea, and delirium. These etiologies can be assessed more readily in awake and non-intubated patient, with assessment being more challenging in intubated and/or sedated patients. According to various studies, wide range of intensive care unit patients experience anxiety and it may range from 12 to 80%. The common sources are fear of suffering or death, loss of control, and frustration due to inability to effectively communicate. The self-report and clinical evaluation are the most widely used methods for evaluating anxiety. Pain is likely underreported in ICU patients, and a significant proportion of the ICU survivors report experiencing moderate to severe pain during ICU care. It can be due to routine patient care like suctioning, repositioning, physical therapy, or it may be due to immobility, trauma, surgery, endotracheal tubes, and other monitoring devices. Patient may report pain on numeric rating scale of 0 to 10 if communicating, or have evidence of pain including grimacing, limb withdrawal, combativeness, diaphoresis, hyperventilation, and/or tachycardia. In such non-communicating patients, behavioral pain scale and the critical care pain observation tool is used since they are simple, valid, and reliable in critically ill patients. This is numeric pain rating scale for assessment of the pain in communicating patient. It allows the patient to rate their pain on the scale of 0 to 10 and 10 being the worst possible pain and 0 as the pain free. BPS or behavioral pain scale is used in the non-communicating patients. In this pain assessment tool, facial expression, upper limb movement, and compliance with mechanical ventilation is assessed. Each of these three parameters are assessed on 1 to 4 scales, so the total score ranges from 3 when there is no pain to a maximum score of 12 defining maximum pain. Delirium occurs in up to 80% of ICU patients and remains frequently unrecognized in older individuals and patients who have hypoactive delirium. Hyperactive delirium is more readily apparent, like delirium due to drug or alcohol withdrawal. Delirium is a risk factor for prolonged hospitalization and mortality in critically ill patients. The risk factor for delirium include patients with electrolyte imbalances like hypocalcemia and hyponatremia, patients with metabolic diseases like hyperglycemia, azotemia, hepatic disease, patients with infection, drug or alcohol withdrawal, malnutrition, cancer, and some cerebrovascular or cardiopulmonary disease. Advanced age and some medication are also responsible for delirium. In the acute phase, delirious patients have impaired short-term memory, abnormal perception, and intermittent disorientation, which is usually worse at night. The assessment tools are used with the understanding that the level of arousal may affect accurate assessment. This includes the confusion assessment method for the intensive care unit or CAM ICU and the intensive care delirium screening checklist or ICD-SC. Both scale assess patient for acute mental status change or fluctuating mental status change, inattention, disorganized thinking, and or an altered level of consciousness. Both scales can identify new or persistent delirium, but neither quantifies the severity of delirium. CAM-ICU or confusion assessment method for ICU is used for the diagnosis of delirium in ICU. It consists of 4 parameters. First parameter is whether there is any acute change in the mental status or abnormal behavior that fluctuates during the day. It means whether it comes or go or decrease and increase. Second important parameter are presence of inattention. Inattention is assessed by observing or assessing whether patient is easily distractible or having difficulty in keeping track of what was being said. These two parameters are important or essential for the diagnosis. Out of the parameter 3 and 4, at least one should be positive to confirm the diagnosis of delirium. Parameter 3 assesses the presence of disorganized thinking. Disorganized thinking is assessed whether patient makes irrelevant conversation or unclear or illogical flow of ideas or unpredictable switching from subject to subject. Parameter 4 assesses whether patient has any altered level of the consciousness. Anything other than alert is altered level and it includes hypervigilant state or presence of lethargy, stupor or coma. Non-pharmacological strategy is either given prior to or in combination with pharmacological treatment. Combination therapy is common since the cause of distress is rarely quickly reversible. Initial non-pharmacological strategy include reassurance and frequent communication with the patient. Over the course of the ICU stay, it also includes regular caregiver visit, establishment of normal sleep cycle, correction of sensory deficit, noise reduction, minimizing use of lines and tubes, relaxation therapy like massage, cognitive behavioral therapy like music, physical and occupational therapy, and caregiver interaction. Even when both non-pharmacological and pharmacological interventions are employed, use of physical restraints may be required if the perceived risk of self or caregiver harm cannot be minimized. Restraint should never be the sole method employed for managing patient in the ICU, and when employed, every effort should be made to discontinue them as soon as possible. Patient-directed self-initiated music therapy with the patient-preferred selection tailored by a music therapist resulted in a reduction in anxiety and need of sedation. So to summarize, distress leading to agitation is common in critically ill patient in ICU, and the common causes include underlying disease or its symptoms like drug withdrawal or alcohol withdrawal, hypoxia, dyspnea or shock, and presence of pain. In addition to underlying cause and or symptoms, pain, anxiety or delirium is an important contributor. The cornerstone of treatment includes management of underlying disease like treatment of respiratory failure or shock, underlying cause of distress agitation, mainly whether pain is contributing to agitation or anxiety is contributing or delirium is responsible for agitation, and treatment for the same by non-pharmacological means. Pharmacological means are commonly used if there is no improvement. Here I finish. Thanks for watching this video. Please do not forget to subscribe to this channel. See you in my next video on pharmacological therapy for sedation and analgesia in critically ill ventilated adults. Till then, bye and take care.